Our first speaker this afternoon is very familiar to us, Dr. William Scherer out of Delray Beach, Florida, a longtime FPMA member. We're always happy to have him speak, and he'll be talking about common pediatric misdiagnoses resulting in malignancies.
Well, thank you, everybody. And I'd like to always just say that, this is always a highlight of my year coming to the FPMA. I look back at my kind of career path, and I realized that the first time I came to the FPMA SAM meeting was in 1987. And for those of you who were not born in 1987, I guess that makes me one of the older guys in the room. With that being said, it's been a real pleasure to have my career in Florida. I was basically raised and schooled here, and I'm really proud of what our association is doing. I have the ability. I go to a lot of medical conferences, and I have the pleasure of always coming back to Florida. And it makes me realize that we do have the best run state association. Not only do they put on what I think is the finest seminar at the Florida SAM meeting, we also have the summer meeting, and putting those two together, most states don't even do one, and the fact that we do two is great. And what they do in Tallahassee for our membership and our dues, basically when you see an officer or you see somebody, just thank them. And if you're a young doctor here, you're just entering practice, consider getting a little bit more involved. If you want to, really expand your practice and kind of do some, building of your career, I think that's a really good move. So other than that, today's lecture, Common Pediatric Misdiagnosis Resulting in Malignancies, is going to focus mainly on skin type conditions. I do want to also acknowledge that this lecture was created with Dr. Ross Todman from PICA. So we created this lecture together last year, and we've given it, I think, in New York or Chicago and a few other places, and I think everybody knows Ross is now officially retired, so he's enjoying probably a cruise ship in the Mediterranean, or hopefully he's having a lot of fun. But I do want to acknowledge that this lecture was created with him, so when we present it, it's usually an hour long, but we kind of go back and forth, where I'll talk about, the diagnosis of the physician, and maybe the treatment options, and maybe where sometimes a doctor fell below the standard care, or just simply missed something, or mistake, or Dr. Ross Todman will then jump in and he'll talk about the legal aspect. So at no point, I'm just an average, practicing podiatrist. I'm not an attorney. I'm not, a guy who testifies a lot or does a lot of legal cases. But what happened is that when we build this lecture, we wanted to really focus on, what we sometimes miss in our practices, specifically related to dermatology, and unfortunately, some of the things that come back and bite us are the malignancies. In terms of my disclosure, I'm a consultant with Baco Diagnostics. There's nothing here that would conflict with that. I am a proud PICA policyholder for my entire career, and of course, I'm a FPMA member for 30 plus years. We'll have to keep adding numbers to that one. Learning objectives are in your booklet here, but we're going to really focus on legal and medical factors revolving around failure to diagnose, and really the warning signs that you should be kind of looking for. We're going to look at improving patient outcomes with early diagnosis and early treatment of malignancies. Simply put, the earlier you diagnose it, the quicker you're treated, the better the outcomes are going to be. A little bit on risk management, and if we have some time for case studies. Again, I've got about 30 minutes for this presentation. It's normally about an hour, so there's some things I'm probably not going to get to. So let's talk about the 6 or 7 things that PICA has shared with me and Ross Todman has shared with me when we created this lecture. And the question really starts out with, what are the cost-based claims against podiatrists? Or what cases are involving ones that involve a lot of money? Whether that is to defend them, or whether it's a settlement, or when they fully go to trial. And this is not necessarily in order here, so I want to be careful not to assume that any one of these is higher. But the first 3 I'm going to focus on the lecture today is failure to diagnose and what we can do for steps to increase our index of suspicion. Number 2, malignancies. Simply put, if you are treating something like a skin rash or a skin lesion or even an ulcer that's not healing, and you don't diagnose the malignancy, and then it ends up a year later, or it metastasizes and they go to another doctor, that can come back and kind of cause you some problems. Diabetic infections, that goes without saying. Our whole careers have been dealing with that. I'm not saying that we're doing anything good or bad with that. It's just that when they happen, a lot of times there's a loss of limb, and that is generally a costly case. Bunion surgeries, I'm not going to talk about bunion surgeries today, and this is not to state that, that a podiatrist has more malpractice with bunions, and when Ross explains it to me, he says, simply put, we do more bunion surgeries than anyone, thereby, even the few cases that we have, it just kind of tilts the needle in terms of cost-based cares. CRPS, DVT, and PE are all things we need to be on the outlook for, simply because they're hard to diagnose, a lot of times we're caught off guard, and then that sometimes can result in significant claims. So these are, again, the top ones to kind of worry about. Elements of malpractice case, again, I'm not an attorney, this is, not a legal expert on that, but these are the categories where Ross kind of takes over. But the failure or delay to diagnose a malignancy is certainly as what they say is the top 5. Meaning of the 6 or 7 I showed, this is in the top 5. And Pecca doesn't like to kind of just say, hey, which one is number 1, 2, or 3. It's just collectively, if we could lower this, it's going to benefit all of us. If you think about that, if we're all insured as podiatrists, the better our colleagues are doing, the lower our rates are going to be. When one podiatrist has to, settle a $1 million case, well, if there's only, 5,000 podiatrists in the company, or 3,000 or 4,000, that's dollar cost averaging. All of our rates tend to kind of get hit with that. So, really the thing that Dr. Thomas always said, that if we could really wish for one thing, is for podiatrists to always have their index of suspicion. Don't let your guard down. I know it's easy to say. So if you're seeing 20 patients a day, you're not going to have an index of suspicion high in every single one, but it's the warning ones, the one that we're going to talk a little bit about today, the ones, that we've already discussed previously. And index of suspicion means, what happens when a physician misses the clinical signs of an infection, or they miss the clinical signs of a malignancy. It's okay to have an incorrect assessment. We are having a differential diagnosis. No one expects a physician to get it exactly perfect the first office visit. But again, if you have a routine ulcer patient, and you're seeing that patient every month for, let's just say, wound debridement, and you have not done an investigation whether it's osteomyelitis, you've not done vascular studies, you've never done a biopsy for a wound that doesn't heal. And if any one of those things kind of pop up in the future, that is going to cause some issues. That is a very difficult case to defend. So what really, kind of the advice to us is that, you have to look at these patients that are high risk, and you have to kind of always cover your rear end, either with diagnostic testing, whether it is MRIs or CTs, or it's vascular testing. And better yet, it is always getting also referrals and having other medical experts in. Make sure the medical doctors, the oncologists, endocrinologists, and you have an open report. How many of you have a very good relationship with a vascular surgeon? Okay? I'd love to hear that. Okay? Well, what about infectious disease? How many of you know that? I mean, somebody who's on your speed dial. Okay? Those are the things that you really, really want. Okay? How many have their CPA and attorney on speed dial also? Okay. Neglect treatment certainly is an element in a malpractice case, and this is where the attorneys kind of fight each other. And this is why we're paying our malpractice insurance, to kind of defend us, even if we made a mistake, and even if there is something where we fell below the standard of care, because ultimately it's going to become a battle of the experts, battle of the attorneys, and really what a jury is going to say. And I'm happy that we're now in 2024, that we're past the days where doctors were getting sued a lot and losing because we didn't have our medical records up to snuff. So we were trained to be doctors, not trained to be attorneys or having always battle with our records in court. And the final one is lack of informed consent. Again, we don't see that a whole lot today, but that is always an issue with any type of malpractice case. So just make sure, certainly not only you have an up-to-date informed consent, but contact a malpractice carrier to make sure you've got the latest version. This is something new that I added recently, and it's called physical exam considerations, meaning these are just a little bit of pearls that I want to share with our profession that are just things that kind of help us when I'm seeing some doctors making some simple mistakes. And when I talked to Dr. Tubman about this, a vascular exam, the thing that he is adamant about is that in your history and physical, the DP and PT pulses 3/4, 2/4, you do that every time you see a patient, is completely worthless in a court of law, simply because it's so subjective. They're going to look at a collection of your notes, and it looks like a clone note, or this looks just like the other one, and everybody 3/4, or all of a sudden everybody is, non-palpable pulses, and then you take that person in for surgery, and now they got a 3/4. So the point of the matter is that it's a very subjective thing that is very easy to attack in court, where something like a Doppler is very objective. Now, am I saying doing a Doppler on everybody? No. But if you have a patient with diabetes or peripheral vascular disease that you send out for a Doppler or do yourself, when you have some type of reading that's in your chart, that becomes a more objective test that is going to help build your case. Same thing with x-rays, MRI, doing biopsies, sending out patients for physical therapy, having those extra records in your chart is beneficial. If you are unsure, order a consult. Get a second opinion. Ask for a medical referral for infectious disease or vascular status. Musculoskeletal. Some of you may know that I taught radiology at foot and ankle at Barry University for about 15 years. I sometimes see a lot of students out there. I know that Dr. Armstrong took over after me, and I think someone else is doing it even now. But I've always had a pet peeve about podiatrists when it comes to MRIs. We are really good at taking and reading our own x-rays, but how many of you just ordered MRI and don't read your own MRI? You just read the report. I cannot begin to tell you how many times the radiologist gets it wrong. Look, they're not podiatrists, they're not clinicians, they're not foot and ankle experts. They're just reading a film. You are seeing the patient. It's up to us to read our own MRIs. Now, sure, we're not going to be able to bill for that. It's going to be maybe part of your E&M. But the fact of the matter is you're now able to correlate clinically with the patient, with the MRI. And if you don't feel comfortable reading MRIs, then just call up your local hospital and say, hey, can I spend a few hours with a radiologist and going over some cases, and maybe your own cases, to learn a little bit about yourself. That, again, just reading the report is not good enough, because a lot of times the radiologists miss it. And I'm just saying, the way it is. We're all too often to prescribe these cam walkers to patients who walk in the door. Now, how many of you are still, or I shouldn't even ask this question, how many are actually still putting on a cast, non-weight bearing cast? The simple treatment of non-weight bearing with a cast will fix a lot of conditions. And the problem with the cam walkers, is we just can't trust our patients. They're going to put it on, they're going to take it off, they're going to say they're compliant, they're going to walk in, and that thing, after 2-3 weeks, it looks like the brain cam walker has never been used. Think about having aspirin daily, when you're going to do a cast. Anybody who's prescribing knee scooters, be very careful with knee scooters. Okay, again, a lot of patients need to be properly trained how to knee scooter. It may sound simple, but when their knee is always bent, that can cause DVTs. Thereby, consider letting patients know how long they can have their knee bent. And also, that we've seen a few cases where these 3-wheel knee scooters, patients are on the corner really quick and they trip and fall. Well, who do they want to sue then? The doctor that prescribed it. So again, I'm not here to say, whether you should refer out for that, but at least you should educate your patients when you're dispensing these type of products. And then finally, when you're looking at dermatology conditions, how many of you have a Woods lamp? How many of you have a dermoscopy? Which is still not a lot, maybe 10%. The bottom line is that if you've got kind of a weird lesion, a weird rash, even a weird toenail, ladies and gentlemen, you just need to send a specimen to the lab. I don't care what lab you send it to the lab. Take a proper specimen, take a biopsy, you actually get paid for doing a biopsy, and send it to a lab. That is a definitive diagnosis, usually. And the problem is that a lot of times what we do is we guess as to what we think is going on. And then we empirically treat by choosing a variety of medications that maybe you've kind of your go-to medications. The bottom line is that I guess that's okay. A certain percentage of patients are going to get better, maybe even a large percentage of patients, but there's going to be a significant number that don't. And what happens is we want to practice evidence-based medicine. And evidence-based medicine is, number one, making accurate diagnosis and then treating it properly. And however you go about doing that. So other pearls of wisdom, again, this was Dr. Cobb and I kind of put these together, and he always likes to say, Bill, I want doctors just always have that heightened suspicion. And of course, I will argue with him by saying, hey, look, how do you have that all the time? And the bottom line is that is the risky patients, the one that we're just talking about. Biopsy sooner than later. Don't wait. Why? Early diagnosis and treatment is going to increase your outcomes, and if you're just not comfortable treating something, refer it out. Don't keep it in your office forever. So these are the cases that I'm going to spend the rest of my time on today, and then we'll kind of jump a little bit into a few case studies if we have time. But the bottom line is that these 7 or 8 or so conditions on the left are the conditions that have been significant podiatry cases involving some type of malignancy that has cost malpractice companies a lot of money. And the conditions on the right were the conditions that the podiatrist generally thought it was. So let's start with the number 1. This is what I consider to be the scariest condition in podiatry. Well, maybe necrotizing fasciitis is the scariest, but I don't really see that a whole lot. The fact of the matter is amelanotic melanoma is a malignant melanoma that lasts melanin. That is very deadly. And the problem with amelanotic melanoma is that there is a delay of diagnosis for significantly longer than even a malignant melanoma that has a dark coloration. So the death rate on this is significantly higher, the metastasis rate is significantly higher because it looks like just a standard ulcer. I will have some slides to show you some differences here. So what happens is the patient presents an ordinary ulcer, and again, does not respond to conservative treatment. X-rays were normal, MRI is normal, vascular study is normal, still not getting better, trying a variety of things, and sometimes these patients doctor shop, sometimes you lose these patients to follow up. But be on the alert for amelanotic melanoma, and I will help patients to show that. Squamous cell or even basal cell carcinoma versus ulcer. So again, the same concept is a non-healing wound or an ulcer. Could masquerade as an amelanotic melanoma or even a squamous cell basal cell carcinoma. So it's really get questions that, okay, well, where do you do the biopsy on this? Well, generally say the peripheral of the ulcer, maybe the 12 o'clock, the 6 o'clock position. I've even heard other benign pathologists say that, look, if you're unsure, take multiple biopsies. And the question is, well, how many biopsies do I do? Can I get away with 1? Do I need 2? Do I need 3? Do I need 4? Dr. Treppel up in New York showed me a case the other day that was really interesting for an ulcer. He did 3 biopsies, at the 12 o'clock, 3 o'clock, and 6 o'clock position, and only 1 of the 3 was a malignancy, the other 2 are benign. Now again, that's the variability of being a doctor. That's the art and science of what we do. So just by doing a single biopsy sometimes isn't enough. Meaning, I'm not telling everybody to do 4 biopsies. I'm saying, you biopsy where you think the individual suspicion is, and then if it's still not healing, well, maybe do a biopsy in a different location. And these, again, are still unusual cases. I'm not here to scare everybody thinking, oh my God, every ulcer that's coming in is going to be this way. But the fact of the matter is that these cases do exist, and when they do exist, they generally cause problems from medical malpractice issues. So squamous cell basal cell carcinomas, we're going to talk about that. I do have a whole lecture that I've given before on skin cancers, not necessarily related to ulcers. And again, one of the things I always say is that in our school and in our residencies, we've always been taught that, okay, we're podiatrists, lower extremity, we're going to see skin cancer maybe every 3 or 4 years. It's not that common. That's what we've been taught. That's what I've heard. However, because I'm doing consulting in the lab, I do research in this area, I start looking at the data, my opinion is changing to the average podiatrist. A patient with some type of malignancy, specifically a squamous cell or basal cell carcinoma, is walking in your office at least 4 times a year. And if you are an average podiatrist or above average podiatrist, and you have a typical practice of seeing 10 patients a day, 4 or 5 days a week, if it has been more than a year since you've diagnosed skin cancer, meaning like, hey, if you've never seen it, trust me, it's seen you. Well, I know Brian likes that one. Because we talked about that. He thinks I should put that on a t-shirt. If you've not seen skin cancer, it's seen you. But the point is that, I'm here sharing my experiences, not only as a podiatrist consulting for a lab, but also a Florida podiatrist. Someone who's a member of the FPMA, someone a member of HICA, and I want us to do better. And what happens is that we are failing. as a profession. I'm not pointing my finger at any one of us. I'm pointing my finger at me. Okay? So what happens is there are physiatrists in the country diagnosing 10 to 15 skin cancers a year. And when I ask them, how are you doing that? Okay, do you have a referral with an oncologist? And the answer is no, Dr. Scherer, I just roll my pant leg all the way up to the knee. I do a comprehensive skin exam on the anterior aspect of the leg, posterior aspect of the leg, top of the foot, bottom of the foot, in between the toes. On every patient who walks in, I don't care if they're coming in for an ingrowing toenail, for heel pain, bunions, whatever. Show of hands, how many here has seen a dermatologist themselves? Okay? That's about 40%. Do yourself a huge favor. In the next few months, just make an appointment for a full body visit for a dermatologist. Number one, we're in South Florida, okay? Number two, skin cancer's on the rise. And number three, you're going to really learn how they can operate so quickly. They come in, head-to-toe examination in about 3 minutes. They'll have a scribe with them, a medical assistant with them, maybe some students rotating with them. They'll be sitting in the chair in their underwear. It's a little embarrassing. Okay. And then also you realize, after you walk out, after getting zapped a few times, biopsy a few times, you get about $1,000 bill, you're going to be like, that's how these guys are driving such nice cars and such big houses. But again, we can do everything a dermatologist can do in the lower extremity. We need to own it. Okay, we need to be not only as good as the dermatologist, we need to be better. The problem is we just don't publish a lot, and we tend to be narrow vision. Someone comes in with a chief complaint of a hammer toe, we only focus on the hammer toe. Let's do comprehensive podiatry. Other things, squamous cell carcinoma being misdiagnosed as a standard verruca. Another thing I always say is that if you have a really, really significant verruca, I like to call it verruca gone wild, meaning there's a really aggressive verruca in an older patient. I'm not talking in a teenager, mind you. A lot of times that's going to be a squamous cell carcinoma. So take the biopsy. Don't do the laser. Don't cut it off. Don't treat it empirically. You need to do a biopsy on this. Plate melanoma, melanonychia, Dr. Brian Markinson lectures on this quite often. He's got excellent lectures on that. We talk about it all the time. Bob Marley died from acanthosis melanoma. You see the streaking in the nail. I'm going to show you some examples in a few minutes. Always be on the lookout. Those are biopsying at the matrix level with a 3mm punch. You're not clipping a toenail for that one. Bacterial infections versus tinea pedis. Look, it's easy, to make that mistake. But when people come in with web-space infections, they're not always tinea pedis. A lot of times with bacterial infections, not only is Staph aureus, a lot of these are MRSA. Just a show of hands, who's seeing a lot of MRSA in their offices? Okay? A lot of the ERs now, they just assume the infections are MRSA, that they're treating it that way. So MRSA is really, really tough to treat when you see these patients. Leiomyosarcomas, bone versus bone cyst, that'll probably be the last one. That was one that was particularly painful for pica. Again, getting an MRI, getting a CT scan, even referring it out if you don't feel comfortable treating these type of conditions. So let me kind of run through the next few minutes with just some pictures here. Amelanotic melanomas, ladies and gentlemen, every single one of these are scary conditions. Every single one of these look not too scary the first time you see it. But these are chronic, non-healing ulcers that didn't respond to conservative treatment. They don't look too bad, but upon biopsy, on the peripheral of the ulcer, they were positive for amelanotic melanoma. Those are the scary ones. Squamous cell carcinoma. Look at the one on the right. That looks, now again, realize that's huge. That's like, 6 feet by 4 feet up on the screen? Of course that looks bad. But when it shows up in your office, a lot of times we're going to think it's just a plantar verruca. And let's try some cantharon, let's try some salicylic acid, or let's just cut it out. The bottom line is you should certainly be sending samples of this to the lab, even if you're cutting it out. Don't throw that sample in the garbage can. But again, a lot of times squamous cell carcinoma is, or verruca is misidentified as verruca versus the other way around. Basal cell carcinoma, a lot of times these are also those non-healing chronic wounds that we talked about. And again, you could biopsy this at the 12 o'clock position. It might be benign. You biopsy at the 6 o'clock position could be malignant. And again, I always try to biopsy where I think the most representative site. So if I looked at this one on the right, I probably would do it about the 2 o'clock position. The one on the left could probably be at the 3 or the 6 o'clock position. Those are kind of the areas, and this is just a guessing game, okay? You're looking to biopsy at the areas where you have your highest grades of suspicion, and those are kind of examples there. I don't think anybody in the room would miss this one, okay? The funny thing about malignant melanoma is, I'm friends with Dr. Tracy Mahovic and Brian Markinson and a few of the other docs, and we do talk about this topic quite often. And sometimes we'll send each other cases of pictures. And Tracy sent me a picture the other day, and I'm like, and it looked like the picture on the left was on the bottom of the foot, and it was like maybe sub 2, sub 3, and I'm like, that looks like a malignant melanoma. She goes, yeah, me too. It's really scary. So she ended up taking a biopsy, and a few weeks later comes back and it's just a benign UV. So again, we I should say sometimes we get it wrong a lot. Okay. So the fact is that by taking biopsies is really providing objective diagnosis to our subjective differential diagnoses of difficult to treat conditions. This one on the right here, I mean, really, if you see these kind of really particularly grotesque type pictures, look, I get it if you don't want to treat that. At least refer it out to another podiatrist that does, or a dermatologist or oncologist or somebody else. Don't just sit on these type of patients. Now, melanoma, this is something that we all see all the time, and this is a tough call. I'm not saying we need to biopsy every single patient who comes in with this. But your index of suspicion rises. You need to do a thorough history and physical, meaning not only do you need to ask the patient how long has it been there, is it on any other digits, but does any other family members have this? What is your shoe gear like? What are your activities like? Is there any pain here? Because guess what? 90% of skin cancer is not painful. So if it's not painful, patients aren't going to complain about it, and they don't come to our office complaining about seeking treatment. They're like, okay, I got a little dark streak on my nail, no big deal. All of these are acroleticous melanomas. There's no trick here. And the fact is that we generally do a 3 millimeter punch biopsy into the matrix. For all of them, maybe with the exception of the top row middle and bottom row left hand, those are nursing home patients, and I would do a biopsy coming in the center of those type of lesions. Does anybody remember what Hutchinson sign is? That's the discoloration around the nail in the upper right-hand corner. If you see that, that is generally a bad sign. So, I recommend getting biopsies of these. A lot of times these result in some type of amputation. I would recommend getting PET scans. I would recommend getting oncology consults. I would recommend medical consults, full workup on these patients. And quite honestly, if you're just not comfortable, refer these patients out. Anybody know the story of Bob Marley, bottom right-hand corner? So yeah, he's 30, look, I love reggae music. I love Bob Marley's music. They're actually coming out with a movie about him, I believe, next month. I'm actually looking forward to seeing that. But he basically had a acroleticous melanoma of the right hallux. This is the only picture I could find of him with his foot bandaged up. And basically, it was misdiagnosed as a soccer injury. He played soccer a lot. He had some brown coloration to the hallux, and no big deal. And then finally, after a year or so of not getting better, I believe a doctor in Miami, when I spoke to Dr. Chet Evans, he kind of knows the story of this. They did a biopsy and said, okay, we want to amputate your toe, and he refused for a variety of reasons. And then it metastasized, and he died at 36 years old. This is 100% preventable with early detection and aggressive treatment, and a patient that is going to follow your recommendations. So signs and symptoms of skin cancer, the first one surprises a lot of doctors that pain is typically not a factor. Patients don't come in your office complaining of painful cancer. They're just coming in for something else. It's up to us to do our history and physical. Any patient who has a recent nevi or mole that has an increase in size, shape, elevation, other things like irregular edges, jagged edges, bleeding when they put on our socks, localized itching, those are kind of warning signs. And do a punch biopsy. That's easy, it's simple, it's quick. Non-healing ulcers. I've spoken to Dr. Jeff Lehrman about this. I used to say 2 to 3 months. If it doesn't get better with conservative treatment, then it's time to do a biopsy. And Dr. Jeff Lehrman said, Bill, no, I disagree with that. I think it should be 1 month. Meaning, if you're a good doctor, you've got a compliant patient, you're doing appropriate treatment, you've ruled out, any osteomyelitis, you've dealt with the vascular. If you're doing all the right things and the patient's compliant, that also should be getting in better in 1 month. And if not, you need to take a little bit more aggressive approach towards diagnosing that's through a biopsy. And I changed my slide based on that, and I agree with him. So these are, the things that we kind of think about and look at. I did a little study when I looked at podiatry data, and I looked at skin cancers from the lower extremity versus total body. Total body, 80% of them are basal cell carcinomas, about 18 to 20% of squamous cell, malignant melanomas at 2%. When I pulled 10 years of data for 15,000 malignancies, all from lower extremity podiatry cases, I found that 56% of the lesions that we see for podiatry were squamous cell carcinoma, basal cell 21%, malignant melanoma 18%, and even Kaposi sarcoma was at 6%. The fact of the matter is I don't have an explanation as to why these numbers exist. I'm not saying that malignant melanoma is 9 times greater in the lower extremity. What I think is happening here is that podiatrists are just waiting to do the biopsy on a significantly advanced case, and by the time they decide to do a biopsy, then all of a sudden they're getting these type of cases. And the last slide I'm going to give, because I know it's 2 o'clock and I'm using up a little bit of my time, and I just want to leave you with this last slide, is that when I did, in fact it was a year ago today here at the SAM meeting, and I've been asking Jeff Lehrman for 2 years to try to pull this data from the FPMA. I said, Jeff, are you able to pull data on biopsies to compare podiatry versus, the MDs and even the nurse practitioners in case? He said, yeah, well, we can do it, and we want to get the most recent data. It took about 2 years to get this answer. And I remember him calling, hey, Bill, you're not going to believe this. And we were literally at the SAM meeting a year ago and he gave me the data. He said, Bill, look, we take the total amount, and that's only Medicare data. Okay, that's the only bias in here. I mean, this is not all the private insurances. He said, look, we take the total number of CPTs for biopsy, including punch and shave and curettage and all this together, and we divide it by the number of dermatologists. We do the same thing for podiatry. The average dermatologist does about 500 biopsies per year. The average podiatrist does about 3 biopsies per year. But what makes it particularly worse is there's like 3,000 or 4,000, maybe 5,000 podiatrists that do 0 biopsies a year. And there's a few hundred that maybe do 10 biopsies a year. And maybe a few handful that might be 20 or 30 or something. But I'm not here to say we need to do 500 biopsies, but if you're a podiatrist and you've done 0 biopsies, it's time to really reconsider that. Other than that, ladies and gentlemen, I know I'm a little bit over my time. I will, again, hang out here a little bit. If you have any questions, grab me in the hallway. I'll be in the exhibit hall afterward. Enjoy this meeting. FPMA really does run one of the best meetings, and I always look forward to seeing this, and I'm always happy being back here. And thank you, FPMA, for inviting me, and have an enjoyable conference.